79.
Yeah, I saw that you are from 79 batch. I am 1954 batch, Kopila is 1954 batch.
Nice.
Good morning, son.
Hi.
Good morning, sir.
Good morning.
Good morning, Yatin.
Kem છે ભાઈ?
Arey, good night. Good night. Sorry. Thank you for joining at such a late thing.
Yes, no, my pleasure.
Yatin, today is my opportunity to refresh your advice for all sleep apnea you have given.
Okay. So, good morning, friends. Welcome back to the Club of Baroda meeting. And such a pleasure to have Dr. Yatin Patel with us today. The best way to introduce him is that he is an alum of Baroda Medical College, 1979 batch. And of course, he's done his MD, MDA, MBA, and he's pulmonary and sleep physician practicing in USA. He is founder Goshen Center for Sleep Studies, Goshen, Indiana, from 1914 to 2024. Oh, that's a long duration.
That's 1994, yeah.
Yeah. And then he's a medical director, America's favorite sleep center, Elliott City, Maryland. He is author of several books, including Sleep Well, Lead Well, and CPAP is Sexy. Voluntary telemedicine services to homeless shelters in TN. And of course, he is friend of a lot of Baroda Medical College students here. And his name was recommended by his batchmates. And thank you, Yatin, for joining us. But this late hour, and I'm sure it is going to disturb your sleep cycle. But anyway, we'll be very happy to listen to you about sleep apnea, the silent killer, and physicians' role in saving life and love. So over to you, Dr. Yatin. You have about 40 minutes to talk, and we'll keep some 10 minutes for interaction. So over to you.
Great. Thank you, Satish Bhai, for having me. And always nice to see the names Hemant and Padmesh, and I think Parita introduced the Saturday Club to me while we met last time. So my goal in next 30 to 40 minutes is as follows. One, I want to make sure that none of you and your family members and your friends drive drowsy, distracted, or drunk. That's one. Try to convince you. Number two, how to diagnose and treat sleep apnea in your patients. And once you treat sleep apnea, what else you can do for your patients and for yourself so that you could be maximally alert all day long and squeeze out maximum life. And then I'll answer your questions. So this is the title as Satish Bhai read. Couple of things. One, it's a silent killer. It is still, even in USA, an underdiagnosed entity. Because if somebody has chest pain, he'll go to the emergency room. Shortness of breath, he'll consult somebody. But if he snores, stops breathing at night, falls asleep at work, falls asleep driving, nobody would consult you. So it is still a silent killer. And what you can do is just ask a simple question, which is, one, do you snore? And two, do you stop breathing? And then, as appropriate, order a sleep study, either a home sleep study or in the lab study, as it is available. And then treat the patient. And it's such a rewarding disease to treat. No surgery, no medications, just CPAP or oral appliance or some simple surgery. And you have turned that person's life around. So it's a rewarding disease. Look for it. So we'll break this talk into sleep physiology, sleep apnea symptoms, diagnosis and treatment, sleep hygiene, good sleep habits for you and your patients, and then I'll take questions and comments. If you have any questions in between, feel free to interrupt. So the sleep, when we fall asleep, say at 10 p.m., first 90 minutes would be this sleep cycle. And then the sleep cycle would keep on repeating for 4 or 5 times, such that with each sleep cycle, the REM, the rapid eye movement, the dreaming stage of sleep, would be longer and deeper. The N3, the non-REM 3, is responsible for physical restoration, and REM sleep traditionally is considered necessary for emotional, intellectual, and mental restoration. Interestingly, the REM sleep, the body, Mother Nature made it such that we don't act out our dreams. So during REM sleep, there are vivid dreams, but the body is completely paralyzed so that we don't act out our dreams. During that phase, because of the muscle atonia, the pharyngeal muscles also lose tone most readily, and sleep apnea episodes and desaturations are worst during REM sleep. And if you remember, the cardiac deaths occur most commonly in the early morning hours when the REM sleep is longest and deepest. So this is the sleep cycles that we talked about. With each sleep cycle, the REM, the blue part, keeps on getting longer and deeper. These are the EEG waves. I just want you to look at wakefulness up at the top and the REM sleep at the bottom. The waves are so similar because the brain during REM sleep, in some cases, is more active than it is during wakefulness. It's fascinating. The oxygen consumption of brain during REM sleep is sometimes more active than it is during REM sleep. Yeah, this is one of the, when we started the sleep center, every morning after the sleep studies are done, I used to explain, show the patients their sleep studies. This is where we had it in 1994 behind the hospital. Okay, this is the alertness. We are maximally alert around 7, 8 in the morning. And what I want you to see is the mid-afternoon, 3 p.m., around that time, 2 to 3 p.m. Maximum number of highway fatalities occur during that time. Most drastic, suicidal almost decisions also, financial, warlike, communication, occur during that time. So be careful when you are in the afternoon driving. Make sure you don't doze off or your driver doesn't doze off. The second time is the midnight to 6 a.m. The alertness is least. And the peak alertness, which is in the morning hours, do your ICU rounds and toughest surgeries during the early morning hours. This is to use Mother Nature's rhythm to your advantage. So we'll talk about obstructive sleep apnea. As I said, it's common. Up to 20% of adults in USA have sleep apnea. And there is a study from AIMS that I'll show you that India is catching up both in obesity and sleep apnea awareness and prevalence. So we'll talk about definition, which is cessation of respiration or shallow respirations for 10 seconds or more. Sometimes up to a minute, as we see in the sleep center. Then what it does to your physiology, what are the clinical features, how do you diagnose it, and what are the treatment options. So obstructive is when the effort continues, but the airflow stops. And central, which is much less common, is when there is no effort and there is no airflow. This is a histogram summarizing 6-7 hours of sleep study. And as you can see on the arousal column, which is the second from the top, the brain keeps on waking up again and again and again and again and again, because every time the throat shuts off, oxygen level goes down, heart rate goes up, blood pressure goes up, brain recognizes the struggle, wakes up for 10 seconds or so, sends a signal, throat opens up, with a loud resuscitative snort, you start breathing. Keeps on happening all night long. It's like somebody standing next to your bed and stuffing pillow on your face for 10, 15, 20 seconds, again and again and again and again. And that's what causes most of the symptoms, morbidity and mortality. By the way, the desaturations in each sleep lab, we have what we call 50-50 club. Each month, we'll have one patient who would drop down into 50% oxygen saturation during one of those apnea episodes. The heart rate would go down into 30s and 40s during one such apnea episodes. Okay. So as I said, USA, quite common. This is physiologically what happens. People with small jaw, micronadia, large tongue, long uvula, narrow posterior pharynx are more likely to have sleep apnea. Obesity, when we gain fat in the body, we gain fat around the upper airway also, which makes it more prone to collapsing. All right. Yeah, so this is the obesity epidemic in India. There's a meta-analysis done by AIMS group. And I was surprised to see that India, 22-24% people have obesity, and it's getting worse. They suspect that in India, 104 million Indians of working age suffer from sleep apnea. Out of that, half of them have moderate to severe sleep apnea. Severe sleep apnea is defined as people who stop breathing more than 30 times an hour. We have patients who stop breathing 100 times an hour, which is almost twice every minute. Commonest one is no symptoms, usually, because it's most common scenario is I don't have any problem. I'm here because my spouse forced me to. I sleep fine. I don't have any daytime issues. And this happens for a couple of reasons. Number one is this is a perfect disease if you want to be in denial. Because all these serious episodes occur when you are in deep, deep, deep sleep and your spouse is also in deep, deep, deep sleeps. This is when thieves do the robbery of your house. So you are not aware of what you are doing. Even your spouse is deep asleep. And then second thing happens is excessive daytime sleepiness. It creeps up on you so slowly that you are not aware of it. That's number one. Number two, when you are sleep deprived, then the prefrontal cortex, which is necessary for accurate self-evaluation, is underactive. So you don't know how sleepy you are. That's the reason you don't seek help. If you ask patients, they'll complain of dry mouth. Spouse would say that yes, he stops breathing. Depression is very common in untreated sleep apnea patient and reverses within 3 months of CPAP treatment. Fatigue as expected because you are robbed of your deep sleep. Perceived pain gets worse, the aches and pains and back pains and morning headaches. Decreased libido, I'll show you in one of the next slides that low testosterone levels are quite common in patients with untreated sleep apnea. Now, excessive daytime sleepiness is a unique symptom, like no other symptom in medicine. And the reason I say that is this is the symptom that will affect your personal life, your marital life, your family life, your professional life, and community health, falling asleep, driving, and killing yourself or somebody else. So it's a unique disease, and it just reverses. If you treat sleep apnea with continuous positive airway pressure, such a day and night difference, such a rewarding thing to do. So this is what it does. It poor school performance also. So majority of the physiology and pathology of sleep apnea occurs because of sleep fragmentation. Again and again and again and again, you are stopping breathing, and brain has what we call microarousals. For 10 seconds or so, if you look at the EEG, that there is a speeding up of the wave, the frequency, akin to the wakefulness rhythm. So sleep fragmentation and hypoxemia, as I mentioned earlier, the oxygen saturation dropping into 40s and 50s again and again and again and again cannot be good for your overall health. So cardiovascular complications follow: metabolic syndrome, increased morbidity, mortality, and decreased quality of life. Systemic hypertension. The studies have shown that people who are on 2 or more antihypertensive medications, 81% of them have untreated sleep apnea. And if you treat sleep apnea, the blood pressure control becomes much easier. Sometimes patients come off of their blood pressure medication. And it's easy to understand because when your throat is shutting off again and again and again and again, there is sympathetic overactivity. These people have higher 24-hour cortisol levels. Their daytime blood pressure might even be normal, but if you wake them up during these episodes and check your blood pressure, the systolic might be 200. Atrial fibrillation is quite common. The recurrence of atrial fibrillation after EP intervention is high in patients with untreated sleep apnea. There is a strong connection between CVAs and sleep apnea. And on the right side, you can see coronary disease, congestive heart failure, exacerbations, and sudden cardiac death in untreated sleep apnea patient. So a lot of reason to ask patient, do you snore? Do you stop breathing? And if they say yes, get them tested and get them treated. So this slide shows the medial prefrontal cortex, which is probably right behind my fingers, is the executive center. And amygdala is the fear center. So sleep deprivation lights up the amygdala activity. reduces the prefrontal activity such that person becomes more paranoid, more combative, more confrontational, as opposed to a team member. Sleep apnea is seen in 50 to 80% of patients with acute stroke. So every stroke patients, you have to get that person evaluated for sleep apnea. And for those patients, in the lab studies are much more accurate because central sleep apnea events are a little bit difficult to diagnose on home sleep studies. This one talks about the survival going down as apnea, hypopnea index. Apnea, cessation of respiration for more than 10 seconds. Hypopnea, shallow respirations for more than 10 seconds, or when you stop breathing 5 to 15 times, which is mild sleep apnea, or 15 to 30 times an hour, which is moderate, and more than 30 times an hour, which is severe. As you can see, the survival goes down as the severity increases. This is how we can restore love in patients with untreated sleep apnea. You treat them, and these physiologies, pathologies, they reverse. Low testosterone level, as we talked about, gonadal hypoxemia, depression, anxiety, poor mood, lack of desire, loss of libido, fatigue, excessive sleepiness, not to mention that snoring is so loud that the spouse sleeps in the farthest room away from the husband. Patients with sleep apnea are also increased risk for diabetes, and the control and insulin sensitivity improves after CPAP therapy. And this lower BMI, about 15 to 20% of patients with sleep apnea have normal body mass index. So not everybody with sleep apnea would be overweight or obese. Something to remember. So ask about snoring and witnessed apnea, daytime fatigue, sleepiness on patient who might be thin. Acid reflux. Lots and lots of patients with sleep apnea have acid reflux. And one mechanical factor, if you think about it, is inspiration. The inhalation is a negative pressure process. The diaphragm goes down, ribs go out, intense negative pressure is created in the chest, and we suck the air in. But just imagine in sleep apnea patient, the upper airway is shut tight, and the body is trying to overcome that resistance. So the diaphragm goes down harder and harder. The ribs go outward more and more, stronger and stronger, which creates intense negative pressure. Air is unable to come in, so the gastric content obliges, they come up to neutralize that pressure. And that's acid reflux in sleep apnea patients. And this reverses with CPAP treatment. How do you diagnose it? Home sleep testing, which is convenient, cost-effective, affordable, tries to mimic the sleep architecture that the person is observing every day. In-lab sleep study is a little bit more involved, much more expensive, but is the gold standard. So if there is any doubt on home sleep testing, do the in-lab testing. And there's still doubt, treat the patient or call me. Yes, so CPAP treatment. I have patients who have told me, a young lady who says, doc, I did not know that something as simple as blowing air in my throat would change my life. And these masks and cannulae used to be so big and bulky and uncomfortable. But now I tell patients that the masks are better, machines are better, quieter, prettier. Physicians are better because they know and understand sleep apnea, how to diagnose and treat, and how to deal with the problems. And the patients are better because they're more aware of the disease and the consequences. So this is one of my favorite interface. It's a Dream Weaver from Philips Respironics. Patients love that. So CPAP, continuous positive airway pressure, as I showed in the earlier slide, is the most commonest treatment recommended by American Academy of Sleep Medicine. That's what we have used. But there are patients who, despite multiple tries, cannot get used to it. And a few other things I tell patients that if your new shoes pinch your toes and hurt your feet, you don't stop wearing shoes altogether. You try a different one. Same thing with sleep apnea. If this mask is uncomfortable, this cannula is uncomfortable, try something else. Keep on trying until you find something that becomes comfortable. And there are patients who, from the first night, would say, I love this, I will not sleep without it. And there are patients who would say that I hate it. But in those patients, you'll have to tell them and you'll have to work with them. You'll have to have them try different interfaces. And you have to have the spouse involved. And then I have had lots of patients who would say 6 months, 8 months down the road, first they say, I would never wear it. And 12 months later, I would never sleep without it. That's how life-changing this simple intervention is. So oral appliance is approved for patients who stop breathing less than 30 times an hour. And what it does is it pulls the lower jaw forward, makes the airway bigger and tighter. Dentists devise that, customized to your anatomy, and then they titrate it more and more. So the side effect of it is drooling, gum irritation, TMJ pain. Yes. And it changes your bite like that. So, but people who have mild to moderate apnea and absolutely failed CPAP, you can try that with a couple of caveats. One, the oral appliances that people buy on the internet, they do not work. Two, they have to be customized by a dentist to your anatomy. And three, you have to have a sleep study after your oral appliance has been maximally adjusted. Now, if you have any ENT surgeons in the audience, this Inspire, which is a hypoglossal nerve stimulation, has become quite popular in patients with severe sleep apnea, people who stop breathing more than 30 times an hour, who cannot tolerate CPAP. I'll show you what it does. Tonsils and adenoids is a wonderful treatment in pediatric patients. So few things to differentiate. When we have sleep apnea, we become sleepy. When kids have sleep apnea, they may become hyperactive. But two, kids with sleep apnea, their growth can be stunted because growth hormone secretion is locked, is tied to stage 3 sleep. And with sleep apnea, the stage 3 percentage goes down, hence growth hormone secretion goes down, hence the growth goes down. That's two. Number three, tonsils and adenoids. If you remove it in adults, it doesn't cure sleep apnea, but in kids, it does. Because in adults, the problem is not just narrowing, but the problem is flabbiness, collapsibility of the airway. In kids, it is anatomical narrowing. Their airway is tight, not flabby, not hypotonic. So tonsils and adenoids, you take them out in kids with snoring and hyperactivity, or kids with sleep apnea goes away. CPAP compliance. Number one is education. You tell them how bad their study shows their sleep apnea is, how bad the desaturations are, what are the consequences. And then you follow them closely. You have them try different masks. Humidification, which all new machines come with humidifier, increases compliance. Open nose is key to success. So if they have nasal congestion, turbinate hypertrophy, get it treated. Fluticasone nasal spray, 2 sprays each nostril at bedtime, also works. Spousal encouragement and spousal support studies have shown also improves CPAP compliance. So this is what that hypoglossal nerve stimulation. ENT docs do that here in IV sedation. It's not a big surgery. They go home same day. The teeny tiny pacemaker is under the skin. One lead stimulates hypoglossal nerve. The other one senses the activity in the intercostal muscles. And when you go to sleep, you use that remote control, that black green thing. You put it close to your pacemaker, you turn it on. And then what happens is you go to sleep, and every time there is an inspiratory impulse, the hypoglossal nerve is stimulated. So the tongue goes away, airway opens and stays open, and you breathe. So this is invasive, but a good option for patient with severe sleep apnea who cannot use CPAP, do not want CPAP, which is continuous positive airway pressure. All right, so beyond that, once you have treated sleep apnea successfully, what do? What else can help a person get maximum out of life? And that's sleep hygiene, good sleep habits that we all should be following or try to follow. Yeah, so use Mother Nature's internal rhythm, our body's circadian rhythm, to our advantage. Go to bed at the same time, get out of the bed at the same time, even on weekends. No caffeine after 1 p.m. Caffeine has a duration of action of 24 hours. So you may not be aware of it, but it robs you of your deep sleep. So it's quite common in India, the tea all day. So you can switch to green tea after 1 p.m. Alcohol puts you to sleep, but it robs you of your deep sleep. 20 to 30 minutes of regular exercise improves your N3 and your REM sleep. A nap, every mammalian species has 2 sleep periods, one at night and second one at mid-afternoon. So that's when most medical errors occur. That's when most highway fatalities occur. That's when most friendly fires in wartime situations. That's where most bad decisions occur. So never pick a fight in the afternoon. And as always, you have heard me, stay awake while you drive, stay awake while your driver drives. Make sure I just lost a dear friend's wife on a trip from Vidyanagar to Srinathji. Driver fell asleep and 2 ladies died on the spot. So be careful. Yes, so if you sleep well, you live well. Poor sleep leads to poor performance. You may people wrongly believe that motivation can improve performance, but motivation can improve alertness only, not your problem solving, not your creativity, not your team building, not your big picture skills, none of those things. So get 7 hours of sound sleep every night. A quiet, cool, dark, comfortable bedroom, no work in bed, no worries in bed. Do a brief prayer before bedtime. Forgive yourself, forgive others when you put your head on the pillow. Avoid heavy lunches. That mid-afternoon drop gets worse when we eat a whole Gujarati thali. Go with low carb. Try to go with low carb lunch, light lunch. Yes. Yes. So this is our alertness. The green is the alertness, and if you can do those good sleep habits that we talked about, you can maximize alertness and maximize life. Just a few things about REM sleep is we dream every night. We may not remember the dreams, but we dream every night. And if we are fortunate, if we try to remember dreams or have a brief notepad on the lampstand and just scribble few things, it may change your life. There have been revolutionary discoveries based on the problem-solving ability of dreaming stage of sleep. The structure of benzene ring, if you remember, the scientist was trying to find out how the benzene ring and can be tied chemically, and had a dream that the snake was biting his own tail. That's when he had that idea. Then the idea of Dr. Jekyll and Mr. Hyde, Sherlock Holmes, came in the dream. So a lot of good things. Try to remember that, and follow those tips and increase your lifespan instantly by being alert all the time. This one just keeps on getting better if you effective lifespan. This is Mandukya Upanishad. I'm briefly sharing that with you because he described, if you look at the lower horizontal line, he talks about the wakefulness, then dreaming stage of sleep, which is Tejasa, then N3, which is Prana, and then Turiya, which underlies all the stages of wakefulness, consciousness, locally and cosmic. Fascinating. So once again, don't drive drowsy, distracted, or drunk. There is no excuse. This is what we used to do for 20 plus hours, years, 20 plus years. Thank you for listening. And I think I stopped in 40 minutes.
Yes, exactly.
All right, I'm all yours.
Thank you, Dr. Yatin. Can you please stop the screen sharing so can have others on the screen?
All right. Escape. Fine. Stop share.
Good to go. So excellent, very useful, very simple, in a very lucid manner, in a very alert manner. You gave so many messages, very comprehensively. A few questions from me and then
Sure.
what are the pitfalls in sleep study? I see, a lot of people doubt the analysis of sleep study. So what is a good sleep study report? How would you judge whether the report is good or no, there are some pitfalls or there are mistakes in that?
Sure. Yeah, so you are talking about home sleep testing or in the lab testing?
Here mostly it is done in home labs.
Right.
What are the various levels of sleep study? I believe there are levels where you get into the laboratory and then there is a home sleep study. Yeah.
Right. So I've seen a few home study reports from India, and here and there, I'm pleased with the quality similarity. That's number one. But in both places, one, whenever in doubt, repeat the test. That's the guidelines by American Academy of Sleep Medicine, that whenever in doubt, repeat the test. That's one. Two is, in our practice, if patient refuses to do the in the lab study, we'll do it 3 days, 3 nights. Sometimes 3 nights in a row, or sometimes first one was not diagnostic, we'll do a second one. If the second is non-diagnostic, we'll do a third one. The other thing about what tells you if the study is good or not is the duration of testing has to be at least 6 hours. That's number one. Number two, apnea hypopnea index must be clearly computed and described. That's two. Oxygen saturations. A lot of the times the probe stops recording or falls off. So the oxygen saturation recording should also be for continuous 6+ hours. So those are the common things. The other things to remember is, if say apnea hypopnea index comes to be 5 per hour or 4 per hour or 7 per hours, you have two choices. Either you repeat the study or you just treat the patient with CPAP. And based on situation, I had our classmate Suresh Patel's brother with borderline home sleep study here in USA, and he says this is questionable, borderline. Should I repeat it? And I said, if you repeat it, it's going to show that you were stopping breathing 5-6 times an hour. On a good study, it would be 9 or 10 times an hour. The bottom line is you stop breathing and you need treatment. And he chose to just be on CPAP. So does that help, Satish bhai?
Yes, definitely. It answers a lot of.
Okay.
Now it's open for others to interact. Please.
The mask you showed on CPAP is excellent. I don't know whether similar is available in India. Some can say some.
I know.
Yes.
I know. I have a few VIP patients from Vallabh Vidyanagar area who consult me through WhatsApp, and I know they are using this Dreamwear mask by Philips Respironics. So it's the key is to find a comfortable mask. Key is to keep on trying and persist.
Hemant, you have to unmute. Please unmute. Yes.
Good morning, all. I have been on CPAP for 8 years. I had a cardiac event, and after the sleep study, I refused to wear CPAP, and Yatin, Haresh, and other people convinced me, and I'm very happy. My hint for my mask is there are different type of faces structure. and different type of mask. So people who breathe from mouth require a full face mask. There are small, medium, and large magnetic mask, strap mask, or dreamwear mask. So there are nasal mask and oral mask, orofacial mask, and normal mask is usually a full nose covering mask with a strap, which I found it very convenient. The weight is only 35 grams and it doesn't push air. The starting pressure is only 4 and it rises till 16. My question to Yatinji, my question is,
Yes.
for raising the awareness, after that I have been doing that sleep is most essential. Even in my preventive oncology awareness social program, I see said that sleep is most essential. My question to you is, cannot routine pulse oximeter be used by the spouse or the victim himself to confirm that I have broken up or he's snoring, and wife or spouse can put a pulse oximeter on the finger and prove that oxygen level has dropped to 80 or 70. And that can induce him that તમને sleep study ની જરૂર છે. You need.
Yes, but you are talking about continuous oximetry?
No.
Or okay, so
means
then
you can give it because COVID has made a Chinese made pulse oximeter available, and people
so
like
there,
us
there,
have
there,
a routine, very good medical pulse
sure.
oximeter. So if you put for continuous, you put a medical pulse oximeter, put it on alarm that if the pulse oxygen saturation reduces to 80 or 9 less than 90, it will beep off. So people who are not ready to get sleep study, because it is quite costly. There are two stages of sleep study. You know, that first stage
Sure.
identifies whether you have sleep apnea, and next day the team again comes and sets up the sleep apnea to titrate your own settings. So
So
these two
the
levels cost about 20.
say that how much?
Yes, 20,000 in India, but in Bombay, the technicians come and get the sleep study done in less than 5 to 10,000.
Wow.
But my question is very specific about the oxygen saturation
Yes,
meter
yes.
used. You know.
Yeah, you can use that to convince person that he needs treatment. The problem with that is multifold. Number one, as I said, most desaturations occur in the early morning hours, 3, 4, 5 a.m., when spouse is also in deep sleep. That's number one. Number two, there are patients, quite a few of them, that the severity of sleep apnea and the severity of desaturations, they don't match. And then desaturations have a lot to do with other factors. Obstructive lung disease, obesity hypoventilation, and all that. So we see you'll miss patients who are normal body weight. You miss diagnosing patients, females especially, who have fewer saturations or the same number of apnea hypopnea index. So that if you keep those things in mind, then we do, like 20 years ago, we did use nocturnal trend oximetry as a screening method to justify treatment. So maybe not even 20, 30 years ago, right? Before these testing became widely available. So yeah, if you keep those two limitations in mind, you can use it. But good
Thank
points. I'm glad to hear about the mask variety and the cost.
No, masks are available at 5,000, but the accessories, like there are filters. There are two filters. One is the dust filter, and on the other is the bacteria filter, and that costs about 500 for the filter. dust filter and 300 or 200 rupees for bacterial filter. You change it, the first filter after 1 year, the bacterial filter every 3 months. And I'm very happy with the supplies and the, the care which the technicians here take.
Where do you get your
All sorts of masks which are suitable are available. At least I could have shown, I was not prepared. I could have shown all the masks on live because my friend like you has given me all the 5, 6 masks. But Indian mask which I got, it's Blue Line Philips, was very comfortable. So I'm continuing using it.
There is a question
And
about
taking and cleaning.
there is a question about choice of CPAP machine also because there is a wide range available.
sure.
Any
Sure.
tips on that?
Right. So in the USA, we have used Philips Respironics machines, and they have lasted. I have patients who have used it for 15, 20, 25 years without any problems. The second machines are from ResMed, which is an Australian company, and they make durable, quiet, sleek machines. So they both provide good humidification, good air pressure, and the real key is software, which fluctuates the pressure breath by breath. Like Hemant mentioned, majority of the patients now are on auto-titrating CPAP machines. So the pressure, say for example, is prescribed 4 to 14 centimeter or 6 to 20. Then what the software does is whenever it senses turbulence in the flow, in microseconds, it increases the pressure and keeps on adjusting the pressure in microseconds. So the software that these two reputable companies, CPAP, have are tried and tested globally. And both of them have, here at least, cell phone chip, the mobile phone chip in that transmits compliance data to physician's office and to the home medical company's office, telling me that Hemant has been using the machine every night for 7 hours and his residual apnea hypopnea index is successful, less than 5 per hour, 2 per hour, 1 per hour, 0 per hour. If there is an air leak that the mask is not fitting well, then also it gives me a percentage of the time that he is suffering from air leak. So those two machines are the only machines that are used in this country. And Hemant, which machine do you have?
Can I say?
Yeah, go ahead.
Yatin bhai, the machine is, I'll give biomedical engineering is continuously evolving. And
Okay.
Philips machine I'm using, the machine which I started was mysteriously recalled by the company,
Yes.
and a
Right,
free
right.
machine was given to me.
Mhm.
And reason was that the lining inside the machine was oncogenic and cancer-causing chemicals were there. Somebody proved it, and then they apologized and gave us the new machines, even us Indians and everybody worldwide. And now machine. The uh, the second thing is, second question is that if you wear it and start it, the machine automatically starts sensing your respiration. So that is not the problem, and it adjusts the pressure and everything. Another thing is chip. There is a chip which you can download the app, the software, Dream Mapper or Philips, example Philips or ResMed or anything. Then you can put the chip in the laptop and you can see your own, generate your report and give it to your pulmonologist for expertise. But the simplest thing is machine itself has settings. So if you rotate the knob, it will give you your daily, what is the amount of sleep machine you use, hours, your apnea, sleep apnea index, and leak. Leak is very important. 99% leak is 99% okay is allowed. 1% leak is if you remove the mask for toilet or anything, you have to first close the machine and then remove the mask so that the false data does not go in. But machine itself has the data, and for educated people, they can easily find out what is the ASI, which should be below 4 or 5. Yatin, am I correct?
Yes, yes, less than 5, we are happy. And also, we do have patients who had 100 per hour of apnea hypopnea index. And if they come down to 11, 12, 18, we are happy.
All data is there.
Right. So there's a question from Kiran Bhai.
Yes.
The machines are so good. All data is there.
It's an excellent question. Snoring is very common, but sleep apnea is not as common. So who do you evaluate? So if snoring and tiredness, snoring, excessive sleepiness, snoring, uncontrolled blood pressure, snoring, witnessed apnea, snoring, history of coronary disease, snoring, history of atrial fibrillation, snoring, history of stroke, snoring, congestive heart failure, snoring, excessive daytime sleepiness, all these patients for sure need to be evaluated. Rest is up to you.
Right.
Kiran Bhai, does that answer the question?
Yes. Thank you. Same way, I
Yes.
want to ask you one more question. You had mentioned that all stroke patients, the sleep apnea is to be, sleep studies to be evaluated. Is it true? Is any guideline suggest that it is?
Yeah, so 60 to 80% of the patients who have acute stroke have sleep disordered breathing. In the earlier parts, in first 3 to 6 months, what we see is central sleep apnea, sometimes chain strokes of aspiration. But after 6 months also, those things go away usually, central sleep apnea. But obstructive sleep apnea, about 30% of them end up having obstructive sleep apnea. So yes, I would err on the side of doing a sleep study. Now, the problem is this, as Satish Bhai mentioned earlier, is majority of these patients are getting home sleep testing, and home sleep testing is not a test for central sleep apnea or chain strokes aspirations. So I'm not sure, does anybody in Baroda or Ahmedabad do in the lab testing with EEGs and leads on the chin and here and chest and legs and all that, 18 different parameters, supervised, tech supervised. So
I am
that's
not
what
sure
this.
whether there is a sleep lab in Baroda or not, but all these things which we are talking about, multiple leads and everything, it is done as home testing only.
Right.
No.
No,
So
but
majority of the test in Baroda are usually done at the home only.
Home only.
Hmm.
Kiran Bhai, is there
Correct.
any
No,
sleep lab in Baroda? Kiran Bhai?
I think it is with Sonia Dalal, I think. It is.
Okay.
Yes.
Yes.
Okay.
But how exactly it fulfills the requirement of that particular lab, I have no idea exactly.
Yeah, so what we want to see is that on sleep study, either whether done at home or done in the lab, the interpreting physician should have access to raw data, as we call it, that such that the person can say that, hey, there is no effort, there is no flow, this is central sleep apnea. Because the computerized interpretation is very inaccurate even in the best of machines to tell us whether it's a central sleep apnea or obstructive sleep apnea.
So who
I
does
think Sonia Dalal is
that
also there on the
interpretation?
screen. Let us hear from
Okay.
him.
Dr. Yatin, who does the
Yes.
interpretation of this? I mean, it must be it takes long time to go through the whole raw data, no?
Correct.
How much time does it take and
Right. So the epoch by epoch interpretation is done by registered polysomnography technician.
okay.
And what I do is I have the 6 or 8 hours of data. The technician looks at 30 seconds of epoch, complete one. And what I look at it, I compress it to 3 minutes so that I can see the respiratory pattern. And technicians are so good that I seldom have to change that this is obstructive, not central, and vice versa. So that's what's done here.
Now, here all sleep reports are seen by all the respiratory pulmonary physicians here, which we have. And for central sleep apnea and neurological problems, we have the central sleep lab facility
Good,
in Baroda.
good.
Where is it?
Some.
I have one question, one last question. It is an inflammatory condition according to the neo theory. So, Sayatin, have you found that patients who are actual sleep apnea victims have increased C-reactive protein?
Yes.
People who are not
Absolutely.
convinced to get sleep study.
No, it's not just C-reactive protein. All the markers of inflammation are abnormal in untreated sleep apnea patients. There is increased incidence of rheumatoid arthritis, Sjogren's syndrome, few cancers in untreated sleep apnea patients. So there is so much cellular inflammation also, because the whole body, every cell of the body suffers from hypoxemia.
So
Free
that is my
radical,
marker. Second marker is that
yes.
you do these studies and then you can convince the patient to at least get the sleep apnea study to rule out that this cause of inflammation is not any other.
Sure. Yep.
Okay, Yatin, last question from my side. You face challenges of differentiating sleep apnea from other conditions in a patient who presents with daytime drowsiness.
Yes. So few things. One, in young patients, narcolepsy is a diagnosis that can cause excessive daytime sleepiness. In another situation, chronic sleep deprivation. The brain needs 7 hours of sleep and it's getting only 5 or 6 hours of sleep, then the sleep debt accumulates. That's very common. I would see patient referred by sleep doctor, hey, this kid is falling asleep in the class or at work and blah, blah, blah. And you look at their sleep habits, they are not getting 7 hours of sound sleep. That's number two. Number three, excessive daytime sleepiness. I see that in patients with pain syndromes, that they are on not glucophage, what's that medication, gabapentin and similar medications to reduce pain. And they'll say, oh, he has narcolepsy. No, he doesn't have narcolepsy. It's the medication, gabapentin, OxyContin, alprazolam, that he has been taking for a long time is making him sleepy. Obesity, hypoventilation syndrome. So those are some of the things can cause excessive fatigue, undiagnosed depression.
Okay.
Good.
We are a little bit overshooting the time, but it will be unfair if I don't read the question and comments in the chat box. One question is, there is a sleep lab in Vadodara. Sonia, okay, that's fine. Do you have idea or recommendations for food habits or practices that is more sleep friendly? Dr. Rajnikant Gajjar.
Yes. Small meal in the evening, not within 3 hours of bedtime, would help. Heavy meal, the process of digestion interferes with sleep onset. Yes. Apart from that, no, nothing specific.
Okay. So I think we end the session here. We overshot by 5 minutes, but a wonderful interaction. I mean, your talk was so good and we stimulated audience to ask so many questions. And thank you so much, Dr. Yatin, for
Thank you.
at your time. It's very late at your place now in the night. And I hope you are not sleep deprived for the day. Thank you so
Yes,
much.
yes.
And
Thank you, everybody.
Thank
Enjoy the weekend.
Thank you. Thank you. Bye.